Uh, uh, Good evening, everybody. I'll be sharing my screen now.
Yeah.
So this is about a large foreign body patient suffered from a trauma. Is the audio and video is visible?
Yeah. So the audio is, you need to, we're not able to hear the audio.
Okay.
The audio is put on mute. You will have to change from there. Yeah.
Can I play Dr. Krishnendu?
Yeah. Please go ahead.
Please stop the share.
Incarcerated large metallic intraocular foreign body, a nightmare. This is a video of how a case of large metallic intraocular foreign body is managed. A 46-year-old gentleman presented to us with history of a penetrating trauma in the left eye 2 weeks back. His best corrected visual acuity was 6/6 in the right eye and only PL positive in the left eye. Patient gave history of a primary surgery in the left eye a week after the trauma. And slit lamp examination revealed that scleral tear repair had been performed in the supratemporal quadrant of the left eye. The patient had also developed a posterior subcapsular cataract in the same eye. Fundus examination revealed vitreous exudation and hemorrhage in the left eye with no retinal view. CT scan revealed a large metallic foreign body lodged intraocularly in the left eye. Vitrectomy with intraocular foreign body removal and intraocular antibiotic injections were planned. As the surgery was started, the foreign body was visible in the vitreous cavity just behind the lens. Initially, vitrectomy was attempted after making 3 23-gauge ports. The posterior subcapsular cataract was found to be hindering the view of the posterior segment at this point, and an on-table decision was made to go ahead with lensectomy. After the lens was sacrificed, the view became much better and a clear corneal entry was made, large enough to remove the foreign body. On the first attempt at removal of the foreign body, it slipped from the grasp. But on the second attempt, it was successfully removed through the anterior approach. It was found to be measuring a staggering 22 millimeters in length. The anterior chamber entry was closed with 3 interrupted sutures. Now, as we proceeded with the vitrectomy, a large tear in the retina was noted in the supratemporal quadrant. The vitreous cavity was found to be full of exudates and hemorrhage, precluding the view of the retina. After some progress was made in clearing the vitreous cavity, posterior vitreous detachment was attempted but achieved only from the disc to the temporal side. The view was again noted to go hazy at this point, and the corneal epithelium was scraped off. Some amount of liquid perfluorocarbon was injected into the vitreous cavity and the vitrectomy was resumed. A membrane-like structure was noted over the disc and nasal to it. Multiple attempts at removing the membrane proved to be futile, with each attempt causing bleeding which obscured the view and had to be cleared repeatedly. At this stage, fluid gas exchange was performed. A few more attempts were made to peel off the membrane, but it could not be achieved. Endolaser was done to the supratemporal break in the retina. An inferior peripheral iridectomy was performed and silicone oil was filled to tamponade the retina, and the case closed after intraocular antibiotic injections. Postoperatively, the patient was put on topical antibiotics, steroids, and cycloplegic agents. Vitreous biopsy revealed Staphylococcus aureus sensitive to vancomycin. At 3 weeks post-op, the vision was counting fingers at 4 meters and fundus examination revealed retina to be attached, and a patch of bare sclera was noted nasal to the disc, presumably at the area of previous incarceration of the foreign body. Intraocular pressure was 18 millimeters of mercury. Minimum subretinal fluid was noted on optical coherence tomography. At 2 months post-op, the vision further improved to 4/60 and IOP was maintained at 10 millimeters of mercury with resolution of the minimal SRF. Thus, even after the devastating penetrating trauma and a large incarcerated intraocular metallic foreign body, the globe could be salvaged and the patient could gain ambulatory vision in the time. Thank you.